Good evening and warm greetings to everybody joining this webinar relating to a very important issue of obstetric fistula. My name is Jennifer Philpot Nissen. I serve as the Programme Executive for Human Rights and Disarmament for the World Council of Churches, which is based in Geneva in Switzerland. The World Council of Churches is a fellowship of 352 churches from more than 120 countries, representing over 580 million Christians worldwide. It was established at the end of the Second World War as a place where member churches can stand together in a place of visible unity in one faith. My particular role is to work with churches and partner organisations to facilitate their access to human rights and disarmament mechanisms of the United Nations, enabling them to raise their own voices about issues of concern to themselves, the people they seek to help, and to their country. And women's rights are a particular concern to us. And I will share my screen. Hopefully you're all able to see that. Within our women's rights work, we have an important campaign, Thursdays in Black, which grew out of the decade of churches in solidarity with women from 1988 to 1998, in which the stories of rape as a weapon of war, gender injustice, abuse, violence, and many tragedies that grow outwards from such violence became all more visible. But what also became visible was women's resilience, agencies, and personal efforts to resist such violations. Our campaign is very simple but profound. We wear black on Thursdays. We wear a pin to declare that we're part of a global movement resisting attitudes and practices that permit rape and violence. And we show our respect for women who are resilient in the face of injustice and violence and encourage others to join us. A few years ago, somebody who has now become a very dear friend, Father Edward Flynn, urged us at the World Council of Churches to join the work he was already doing, looking at the issue of obstetric fistula as a human rights violation and work to prevent more women suffering in such a way. For the first few years, we consistently made statements at the UN Human Rights Council, imploring member and observer governments to pay attention to this hidden issue. We will continue to do this because there's still insufficient awareness and attention paid to this issue as a human rights concern. That's just a quick snapshot of the Human Rights Council, the room where all the meetings take place. In November of 2022, the Executive Committee of the World Council of Churches issued a statement on global health and well-being, which addressed obstetric fistula, stating that churches have a critical role to play in supporting women in their communities suffering in this way, raising awareness about the concern, confronting discrimination and stigma attached to the issue, and advocating for the prevention of the condition through adequate healthcare, access to repair surgery, and for all affected by this condition to be treated with dignity and respect. Earlier that year, we had started to think about where to visit to both demonstrate our solidarity with those affected by the condition, to learn what was being done to both treat and prevent the condition, and to support our churches and partners to raise awareness about it. Madagascar was our first destination in November 2022. Why Madagascar? Well, for a few reasons. There hadn't been a World Council of Churches visit to our member churches who are part of the Council of Christian Churches in Madagascar for quite a number of years. So a visit was very much due. But it's also a country which appeared to have a relatively good awareness of the issue. And the Ministry of Health had a national strategic plan for the elimination of obstetric fistula, which was renewed every 4 years. As we really wanted to improve our own knowledge through such a visit, we didn't want to start by visiting a country where the issue was largely unknown and little or no measures were being taken to address it. So there's, just in case you're not entirely sure where Madagascar is, there it is in relation to Africa, and the bottom picture is a photograph of the capital, Antananarivo. Our visit confirmed that the accessing of reliable and current data about the extent of the problem is one of the biggest challenges to meaningfully addressing it. Data available from UNFPA dated back to 2010, which at the time had estimated that 50,000 women and girls were suffering with this condition that year. No data collection had been carried out since then, and this figure was still being quoted as the official number of cases in the country. UNFPA informed us that they did intend to carry out new data collection in the near future. We learned that there are an estimated 4,000 new cases each year, whilst the country at the time of our visit in 2022 had the capacity to carry out between 1,000 and 1,500 repair surgeries each year. Now, I'm not much of a mathematician, but clearly the estimate of 50,000 cases in 2010 is not going to be representative of the current reality. So who are the women suffering in this way? I'll share one story, that of a woman who we will call Moira, who shared her story after having surgery in 2022. Moira was 21 years old and had been living with obstetric fistula for 6 years. She was a farmer, growing rice, cereals, cassava, banana, and raising chicken and ducks in a rural area, far from medical facilities. She was pregnant at the age of 15, and when her labour started, she went to a traditional midwife and stayed with her for 3 days, but her support was not enough. She was then sent to a hospital, accompanied by her aunt. They tried to go by motorbike, but the road was so bad that they found it was better to walk than to ride the motorbike. They then decided to try and find a taxi to get to the hospital, and it took them 3 days walking to get to the taxi, staying with family members who lived along the way. She was in labour this whole time and describes being so stressed, much more so for her child than for herself. She thought she would die with her child, but she kept hope that she would arrive at the hospital in time. She had never been to the city before. By then, she had been in labour for 6 days when she arrived at the health facility, and it was one more day before they decided to do a caesarean section. Sadly, her child was stillborn. She then had a fistula operation for the first time, but only stayed in hospital for 2 days as she had so little money to pay for the care that she needed. It seems that the repair surgery was either inadequate or she didn't have time to heal properly, because she then lived with obstetric fistula for 6 years. She had the second repair surgery after hearing about the possibility on the radio, and she shared that her father told her he had also heard about a hospital that did repair surgeries. This is an important point to note, because gender inequality in some affected countries can mean that women need permission or encouragement from fathers or husbands to go for surgery. She met a woman who had been a patient at this hospital who had come back after a fistula repair, which is also an important factor because there are high levels of fear and mistrust of hospitals and medical staff, which can lead to women not coming forward for surgery. Myra shared that if she had had funding for transportation to the hospital, if local medical facilities and more skilled midwives to advise her to go to the hospital earlier were available, this would have helped her and would help all the women in her village. She said that she knew of 4 other women suffering from this condition in her village and neighbourhood, but following her surgery, she felt very happy and joyful. The churches we visited in Madagascar had very varied levels of knowledge about the issue. Some admitted they knew nothing but wanted to help. Others already were contributing to efforts to reduce the levels of obstetric fistula in different ways, including raising awareness of the need for appropriate prenatal care, education, sensitisation programmes to avoid early marriage and early pregnancy, provision of fistula repair surgeries, and socio-economic support for women who are affected. Their concerns were particularly for women and girls in remote and rural areas due to the lack of available and adequate health facilities. During the visit, several asked us about any existing resources and information to guide them and for them to share with their congregations. So when we came back from Madagascar, we felt we had definitely had a challenge to try to produce something which would be of use to the churches, a guide which would help churches to work for advocacy for the prevention of obstetric fistula. At the time, I was assigned a student from our theological college. There's usually 7 or 8 students doing a master's in ecumenical studies, and each one gets assigned to a different staff member at the World Council of Churches to work for about 4 to 6 weeks in March or April. of each year. And I was assigned a young lady from Kenya who was a formidable person, just absolutely incredible. And she'd already expressed some interest in working on gender issues. And so I said to her, well, would you be interested in providing a first draft of this guide that we wanted to write? And she was very interested in that. And several weeks into her time with me, she confided in me that she was actually living with some level of obstetric fistula herself, and she hadn't even told at that time her family members. It was quite an incredible story. She went ahead and wrote a fantastic first draft, which we then shaped with many other writers contributing. But when she felt empowered by what she was reading and what she was learning, and when she went back to Kenya, she sought out an organisation that could help her have repair surgery, and that took place in the September of that year. And she then became a real advocate, encouraging all women who she knew who either knew people or were perhaps at risk of this happening themselves, and speaking out as loudly about this as she can. She started blogging and sharing her story with everybody. So it was a real moment of empowerment, and we were so thrilled that she had been involved in this process. So we released our guide for churches for the prevention of obstetric fistula, and you can, if you Google it, you'll find it, but the link is at the bottom of that page. And this is now available in Malagasy. We wanted to make sure that our churches in Madagascar had access to it in their own language, and we've since released it in Portuguese for reasons that I will now explain. So very motivated by the visit we'd had to Madagascar, we looked for another country to do such a visit. And this took place in January of this year, when we were able to go to Angola. We were also, again, motivated by the need to visit member churches there, and it's a country with both awareness and action to address the concern. So accordingly, we translated the guide into Portuguese ahead of the visit. What we learned in Angola pretty much confirmed what we'd heard in Madagascar, that the primary cause of obstetric fistula is a lack of access to well-equipped medical facilities and quality care when women most need it at the time of obstructed labour. But there are a whole host of other socioeconomic determinants which can lead to this situation. A lack of adequate nutrition throughout a woman's life, right from her own childhood, a lack of adequate medical care throughout her pregnancy, limited education, lack of options in her life, which perhaps led to early or multiple pregnancies, gender inequality, which took away her right to make decisions over her own body, such as when to seek medical care, or her ability to access family funds to pay for emergency care. In our guide, we attempted to address some of the misleading theologies which appear to possibly contribute to the occurrence of obstetric fistula in Christian context. Genesis tells us that when Adam and Eve first sinned against God in the Garden of Eden, God said to Eve, "I will make your pains in childbearing very severe. With painful labour, you will give birth to children." And that's Genesis 3:16. And this verse is sometimes interpreted to mean that taking medication to mitigate the pain of childbirth or seeking help during labour is a sinful bypassing of God's curse. However, these treatments should instead be seen as a blessing from God that allows medicines and procedures to be developed that can help women and ensure the healthy birth of God's children. In fact, several verses in the Bible indicate that plant-based medicines are a gift from God, such as Ezekiel 47. A former colleague of mine from another affected country in Africa told me that women in labour are sometimes reluctant to go to the hospital until the very last minute, as they fear being mocked for not being able to withstand the pain and somehow failing in their Christian duty. And as we know, such delays can put the life of both mother and baby at risk. Thousands of church congregations in affected countries have women suffering from obstetric fistula living among them. In some cases, pregnant women who were previously very active in their church and local community simply disappear from public life. The family might tell people that the baby died and the mother is unwell, but then they say nothing more. This further perpetuates the silence and lack of general knowledge surrounding this condition. So we consider that churches have a very unique place in society compared to other social structures, such as places of employment, education, or leisure. Churches are or should be places where caring for each other is a primary responsibility. They provide grassroots access to communities, and they could be places where pregnant women can seek support, financial, moral, and practical, throughout pregnancy and as they approach delivery. Churches should be places where people can gently and sensitively inquire about women hiding away with this condition of obstetric fistula, and then take steps to ensure that they are helped. Speaking on this issue from the pulpit and in women's, men's, and youth groups could help to raise awareness and address stigma and discrimination, and encourage the hidden sufferers to seek help. Such work can also particularly focus on husbands whose wives might be suffering with this condition, or on men who might face it in the future in their marriages. So I think that's all I would like to share with you at this time. I thank you very much for inviting me to be part of this webinar, and I'm extremely sorry that I can't be with you in person. At the time that this webinar is going out, I will be celebrating with my daughter, who is just graduating from school. So obviously it's a very important evening for us. But I wish you a very good seminar, and I will look forward to watching the recording at a later date. Thank you very much.